I think what changed the trajectory of this case is the bedside nurse trusted their gut. They had a patient, they had a bad feeling about it. They called for an assessment and they were worried that the trajectory was being missed. And I think fundamentally the confidence, the security to be able to make that phone call was the thing that made the difference.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response Run podcast. Today's episode is a little different, and I'm really excited about it. I'm joined by Dr. Oscar Mitchell. He's a pulmonary and critical care physician at Penn Medicine, Associate Director of the Center for Resuscitation Science, and Director of the Medical Rapid Response Team at the Hospital of the University of Pennsylvania. I have been looking forward to this interview since last year when we planned it, because it's always a treat to talk with another resuscitationist who is just as passionate about rapid response teams, early recognition, and resuscitation excellence as I am. Dr. Mitchell has spent years not only leading rapid responses at the bedside, but also researching what happens when patient deterioration is caught early and what happens when it's not. So today, we're going to walk through the same patient twice. First, we'll meet this patient at 5 p.m., critically ill, crashing, and septic shock, when a rapid response is called late and the team is forced into full high-stakes rescue mode. Then we'll rewind the clock back to 10 a.m. Same patient, same underlying pathophysiology, but this time a bedside nurse senses something isn't right, speaks up early, and activates the rapid response team before the patient spirals. We'll break down what changes between those two timelines, the assessment, the interventions, the teamwork, and ultimately the outcomes for the patient. So let's do this. Dr. Mitchell, welcome to the podcast.
Thank you so much for having me. I'm so excited to go over this case with you twice and spend some time talking about a topic that I'm really, really passionate about, which is patient deterioration.
Oh, good. And at some point in this episode, we will dive into your research as well, but I think let's frame it with these two cases. Okay, let's jump right into the same. So rapid response is called for unresponsiveness. The patient is a 50-year-old female. She's pale. She's diaphoretic. Her GCS is only 6. She was admitted 3 days ago for a small bowel obstruction. So let's say the two of us arrive on scene. We're getting vital signs. Blood pressure is a whopping 70/30.
Wow.
Heart rate's in the 140s. She's breathing 36 times a minute. They're trying to get a pulse ox. They can't get one. Her fingers are so cold and poorly perfused. Okay, this is quite a resuscitation. This is quite a rapid response, right? So when you walk into this room at 5 p.m., with all this information, what's immediately going through your mind? What are your initial priorities?
I mean, goodness gracious me, pointing out the obvious, this patient is really, really sick. This is a patient who is literally going to go into cardiac arrest unless we do everything right and do it really quickly. So I really like to use a framework that I learned as a trainee in my first year of working as a doctor in the UK, which is, I know, taught everywhere, just the ABC framework. I like to do a quick airway assessment, think about the breathing, think about the circulation, and that really frames how much I need to get done.
Okay.
But a lot needs to be done, and it needs to be done really quickly. So we're going to want to get hands on deck.
Okay. So using the ABC framework, what are we addressing collaboratively as a team?
So off the bat, yes, I'm worried about this patient's airway. I want to make sure they're not obstructed.
Okay.
If they are, that's a patient where we're going to want to be doing some bag valve mask ventilation, make sure that's not the cause of their hypoxemia, make sure that we have a respiratory therapist in the room. and people who can intubate this patient if they need it. I don't think they're ready for it right yet. Then we're going to make sure we get some oxygen on them. We're going to make sure that we're providing 100% either via non-rebreather if they're doing their own breathing or via a bag valve mask if they're not. And then we're going to make sure that we're going to support this patient's blood pressure. So we're going to need good access. We're going to need probably vasopressors. We're going to need fluids. And these things, they're not happening sequentially. In this patient, they have to happen at the same time. Mm-hmm. We need to make sure that we have experienced hands who are able to do these things and do these things in concert.
Okay. So you just named a lot of things that have to happen at once. So this brings me to my next question. In these critical situations, what does the ideal nurse-provider collaboration look like? There's a lot of things to be done from a hemodynamic standpoint, from a breathing standpoint. How do we collaborate as a team? What's your role? What's my role?
Well, I think it depends on the setup of your rapid response at your hospital. We do a lot of co-leading where the critical care attending will co-lead with our nurse coordinators who are our rapid response nurses. I know it changes a lot between hospitals. But like I said, we're going to have a lot of people here. And so this is where we as experienced resuscitationists, as rapid response leads, can make all the difference to how this rapid response goes, whether it's pure chaos with 100 people in the room, no one really doing anything, or whether it's one of those beautiful resuscitations where everyone has a role, everyone knows what they're doing, communication is closed loop and clear, and the patient is saved from the jaws of death. And I think that we as the team, as the rapid response team, have a lot to do with which of those scenarios we see.
Love it. So at least in my hospital, the way this would often look is the physician, nurse practitioner, or PA would be there kind of saying like what their priorities are. We need to get ready for an airway. We need to get this blood pressure up, and kind of like saying the things. And then me as the nurse, I am scanning the room and kind of delegating tasks. So for example, based on what I know who's in the room, who's the best person to get access, who's the best person to get this patient on oxygen, who's the best person to mix up the vasopressors, and just delegating each of those tasks that must be done. Everyone just kind of going, like you said, at the same time to achieve the best outcome for this patient. Okay, back to the case a little bit as far as like the details there. What tells you that this patient has been deteriorating probably for hours and not just minutes?
Well, we know this patient is septic. And what we know about sepsis is that this tends to be a disease, a syndrome that develops, yes, over hours, sometimes many hours, sometimes a few hours. Because of the small bowel obstruction, they are at risk for a more kind of hyperacute presentation. Maybe they aspirated, maybe they had kind of a vomit that didn't quite make it out, and that's in the lungs, and that's why they're really sick. Or maybe they had a perforation that led to kind of really, really terrible shock on top of the small bowel obstruction. But typically what we'll see and what we see from the literature is that patients have progressively less subtle signs of deterioration in their vital signs, in their clinical exam, in their labs for the matter of hours, sometimes many hours.
I often will go to rapid responses and the nurse will be like, they were fine this morning. Like, that's great. But they're not right now. And she's trying to get information about what led up to this event. And I will say it's unfortunate that oftentimes vital signs are only taken every 4 hours. And a patient's vital signs can change dramatically in 4 hours. So there's so many other clues that we should be looking for, especially as bedside nurses who are with the patient, aside from just waiting for the vital signs to crash. In your experience, how often do you see cases where the signs were present earlier, but escalation didn't happen?
I think the easy answer here is to say all the time. It's very, very common that patients have evidence of deterioration on their vital signs. When you finish a rapid response and you look back at the chart, you see, oh, yes, that heart rate did start trending up earlier, or that the pulse pressure was getting narrower and narrower. But hindsight's 20/20.
It's true.
I think that what is really important is recognition of deterioration, but also listening when you're called about a patient. And the cases that I think are really tough are when someone was worried and did try and escalate, and then that didn't land on receptive ears.
Yeah, I agree with that 100%. From your experience and your research, what would you say are some of the barriers to calling a rapid response or to escalating or speaking up? What have you found in your research and in your practice?
Well, I think first of all, it's important to say everyone's really busy in the hospital. I wonder whether that underlies some of these barriers that people are feeling. And when I talk to nurses and I talk to providers, I think that some of these perceived barriers fit into different categories. From the nurses, the things that I hear the most are, gosh, I was worried about that patient. I didn't want to be wrong. I didn't want to call a rapid response and for everyone to arrive, 20 people who are doing other things and come to the patient's bedside and then tell me that the patient's fine and they didn't need to go to the intensive care unit and that everything was happening perfectly already. And in my mind, that's the perfect scenario. That's the ideal rapid response. We come and we see the patient, we allay some fears, and the patient does great. And I would much, much rather 5 rapid responses that are called on patients that are being appropriately managed who don't need to come to the ICU than 1 rapid response of a patient who's just about to code like this poor patient in the scenario we're discussing.
Yeah, I agree. I definitely have seen that too. So back up a little bit, my hospital previously did not have a dedicated rapid response team. And so if a rapid response was called, the ICU charge nurse would leave the ICU, leave their whole team of staff and of patients, and come to the best of the crashing patient. And of course, they're trying to get back to their home unit, go back to their staff they have to lead. And so when there was no dedicated team that just did rapid responses, there was kind of the culture of don't bug us unless you really have to. Or can we get over with this? I need to get back to what I'm doing. And I feel like that culture definitely impacts when rapid responses are called, how often they are called. So then fast forward, I started the team 5 years ago. Dedicated team. That's all we do is respond to prevent emergencies. And we made it very clear, you're not pulling us away from the ICU. We are here for you. Call us early, call often. It's not a bother. We the culture that you're trying to promote of I would rather you call and it not be an emergency than you wait. And now we have this patient, this crashing patient that probably could have been prevented hours ago. So we pushed that culture. We saw the amount of rapid responses double. Obviously, they're calling us more now because they're not afraid to call, but we saw the amount of code blues cut in half. So I will gladly go to double the amount of rapid responses, fix the patient up, prevent the code blue, than wait until this patient is blue. I mean, how many times have you heard rapid response 205 and then 3 minutes later, code blue 205? Right. You're darn it, missed opportunity. Could we have caught this earlier?
I think having that dedicated team is so important. That's really borne out in the research that's been done. And I think it's for those reasons. So you have a dedicated team. They're not rushing away to get anywhere else. But it comes with additional benefits. So when you pull someone away from a unit, you're not just impacting the patient during the rapid response, but you're also impacting the care of the patients on the ICU. That charge nurse, they probably wasn't sitting around doing nothing. They probably were really, really helping out in the unit. So there's that side of it. But then there's also what happens when this dedicated team isn't at rapid responses. I bet you spend much of your day going from floor to floor, from unit to unit, checking in with the charge nurses, with the new nurses, with the orientees, introducing yourselves, making sure that everyone knows your face and is comfortable with you. And I think that goes to the culture of rescue, of rapid response, in a way that just can't be accomplished by a team that has 100,000 other tasks to do.
The other benefit is because I get to have the time when it's not just an emergency every time, I get to do all this proactive work and talking with them. I get to know the nurses too and know what their skill level is, their competency, they're comfortable with emergencies. So when we do have this crashing patient, I know who I can delegate which task to. It's not like a fresh face every time. So it really helps the coordination and facilitation of the resuscitation, knowing who's in the room. It really makes a big difference.
Yeah.
Okay, so barriers to calling a rapid response, I agree. I would say the number one is I didn't want to bother people. I didn't want to be wrong. And then the other one is just a fear of maybe the backlash, this is an emergency, maybe the condescending attitude. So I think those two kind of go hand in hand, but both of those are a culture issue.
Absolutely.
it's not necessarily like a problem with the nurse. It's like the culture is not supporting the nurse to speak up and advocate early on.
I think we as rapid response leads on an administrative standpoint in our hospitals on podcasts like this can go, I think, a long way to saying, thank you for calling us. Thank you for calling us early on this case, or come back after a rapid response, after the dust has settled, and spend some time doing a bit of a debrief. And I think that's another thing that you can do when you're a dedicated team. From the provider standpoint, I think sometimes there's a feeling that calling a rapid response is a failure on their part, that they didn't adequately manage this patient's sepsis, that they allowed this patient to deteriorate on their service. And to those folks, I say, and this was a lesson that I think we've all learned, is the rapid response doesn't just bring a bunch of the critical care attending to the bedside. It brings experienced nurses. It may bring a pharmacist, a respiratory therapist. But beyond all, it brings a second pair of eyes. And so I would never call it a failure of the team. It's just asking for help. And I think that's really important to highlight.
If you think that it's a failure, then you're going to discourage the nurse from calling a rapid response. But if you think that this is a great utilization of the resources we have in our hospital, maybe it'd be called, more often. Okay. So let's just summarize this case so we move on to the better option. All right. So this patient, we got her stabilized enough to get to the operating room. Blood pressure was, barely holding on with a ton of norepinephrine. Got her to the OR. They did actually repair her bowel, but at this point, she had such severe septic shock. She developed ARDS, renal failure, ultimately multi-system organ failure. And a week later, she's still in the ICU, on the ventilator, on multiple vasopressors, and the family elected comfort care, and she ultimately passed away. So this, unfortunately, is often the outcome of these patients. I meet them on the rapid response, but a week later, they are no longer with us. And that is what I want to prevent. This failure to rescue, this was a patient that possibly could have been turned around if we had acted a little bit earlier. So after this terrible news of this fake case, let's transition to the better option. Let's move on to maybe 10 a.m. earlier that day. So we're rewinding the case. Same patient, same diagnosis, but now it's 10 a.m. Okay, so the nurse notices the patient is a little bit more drowsy and just not responding quite as quickly as whenever they had passed morning meds that morning. They're just not quite themselves. The nurse's gut says something's up. They're also concerned because the respiratory rate is a little bit faster and the patient's a little bit tachycardic where they weren't before. Okay, so vital signs at 10 a.m. for the same patient were a heart rate of 110, blood pressure at 91/50, respiratory rate is 24, and oxygen saturation, they actually can get a sat now, and it's 94%. Okay, so again, these vital signs, nothing would be like flagging red in the chart with this, right? But the nurse is like, something's up. So the nurse calls the doctor, lets them know what's going on. The doctor feels like the current interventions that are in place are appropriate for this patient, maybe order some fluids for the blood pressure and the heart rate, and kind of, moved along. So even though this patient didn't quite meet criteria for like an automatic rapid response, the nurse still called the rapid response just out of concern for this patient. Their gut told them something was going on. Okay, so let's talk through this case. Nothing here for me is screaming like, code, call a rapid, oh my God. But if you responded to this, what concerns did you have? How would you kind of respond to this at 10 a.m.?
Well, it's 10 a.m., but not too early. So I've at least had my first cup of coffee. So I'm able to come to the patient bedside. And you're right, nothing screaming code, but we have some time to kind of really take stock of this situation. So I'd chat to the bedside nurse. I'd make sure that I came to it with a framework that a colleague was calling me with a concern. This is a nurse who knows the patient really well and amazingly had the patient yesterday. I think that's such an important thing to highlight. This is someone who knows the patient, spent the better part of 12-hour shift with the patient, and can tell that something's changed. And I think that's really important. So I would look back, I would see whether the patient's heart rate and blood pressure changes were new. Maybe they were hypertensive yesterday. Maybe they held the patient's co-reg in the morning, and get an idea of what trajectory this patient was on. Chat to the nurse, make sure I really understood what their concerns were, and then start assessing this patient.
Okay, very good. I wanted to add too, just to help shift that culture, I often find, and maybe this is just my hospital, I think it's actually an international problem, is the respiratory rate is the least reliable vital sign because people don't actually count the darn respiratory rate. They're just like, everyone gets a 16. Everyone's breathing 16 times a minute. So the fact that this nurse noted the respiratory rate was 24, I would start by saying, thank you for actually counting a respiratory rate. 24 is actually something concerning. Now, if the patient had just walked with physical therapy and they're breathing 24 times a minute, no big deal. But if they're just laying in the bed, breathing 24 times a minute, that is something to be noted, and something's concerning about that. So thank you for counting the respiratory rate, and thank you for giving us a call. Let's investigate this together. Okay, the next thing I wanted to address is the blood pressure. So technically, this patient still has a blood pressure that's within normal limits. And I would say early in my career, I would have labeled them as, quote, stable, just based on the blood pressure. So why is relying on blood pressure alone potentially harmful, and how can it cause us to miss earlier signs of deterioration? Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So, if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes.
Great point, great question. This is a patient who has, a stable or soft blood pressure, a phrase that I just hate. And I think it's really important for us to recognize that this is a very, very crude measure of macrocirculatory hemodynamics. We're using the blood pressure in an artery in the upper arm to see whether or not a patient is perfusing their organs, because that's really what we care about. And I think we have some evidence here that this patient may not be perfusing their organs. We see a change in mental status, and that's absolutely an organ dysfunction. We see tachypnea, that's another end organ dysfunction. And then we see tachycardia with this heart rate. So I'm worried about this patient. They're going to pique my interest and make me look a little bit more into this case. I've started doing capillary refill time much more, really integrating that into my practice since the publication of these Andromeda shock trials. It's so easy and it gives you so much information. I really think this is a patient I would walk into the room, introduce myself, and immediately check that finger cap refill.
Yeah. So just to point out, to do this type of, if you want to call it advanced assessment, it just requires pulling back the covers and actually touching your patient. You can't just stand at the doorway and look at the monitor and say, oh, the blood pressure's fine. This requires actually assessing your patient. So yes, thank you. I love that about the Andromeda shock trials because it helps us go back to the basics of patient assessment.
And then while you're there pulling back the covers, of course, feel the knees for how warm they're going to be.
Yes.
And like you pointed out in one of your other podcasts recently, check for that mottling, because that is one of those signs that's going to raise the hairs on the back of your neck and make you really, really worried.
Yeah. I had a rapid response yesterday and the patient was mottled and there were some nursing students on the floor and I was like, y'all come in here. I want you to look at this. This is mottled. Ingrain this in your memory. When you see this, you should be concerned. Okay. Yes, I agree. All right. So when the nurse says, I don't like how this patient looks, how do you interpret that as a physician?
Good question. I mean, like I said earlier, I'm going to consider this as a colleague with expertise who's worried about a patient, no matter whether they're fresh out of school or whether they have 40 years of experience on the floors. And first off, they're telling me I don't like how this patient looks. Not I don't like their vital signs or I don't like the antibiotics this is on. So I can't agree or disagree with them until I am also at the bedside looking at the patient. If I can't get there immediately, I'll see if a colleague can go, because that is a really worrisome description. Particularly if someone can't put it into words. It may just be additional respiratory distress. It may be that they look toxic. They may have that kind of gray, mottled appearance and just really struggling to describe how that is. Hopefully it's nothing, because some people do look pretty bad at baseline. But I'm going to assume that this is a patient who's had a critical clinical change until I'm at bedside with that nurse.
One thing I want to teach, especially newer nurses, is when you say, I don't like how they look, I have a bad feeling, are there any data points that you can add to that to help paint a picture when you're calling a doctor, calling the provider to let them know about your concern? What data points would you say nurses should be really leaning into, assessing for? Which numbers are alarming? Which ones are not? What kind of information would you like to have if you get that phone call of this patient doesn't look good? What do you want to know?
Of course, I'm going to want to hear the vitals. Of course, I'm going to want to know the story for the patient. I'm also going to want to know whether you took care of that patient yesterday, whether they look worse than yesterday, whether they've got worse over the course of the shift, and whether the night team, assuming this is during the day, were worried about the patient as well. These are all really, really important things that often are just not particularly well captured in the EMR. If you call me with a cap refill, I will be thrilled. And then, of course, there are some really important signs that I think are often overlooked. So I think hypothermia, hypoglycemia, things like that can really, really raise my level of concern.
Okay, that's good. All right. So back to our case, what changed the trajectory of this case? From a physiologic standpoint, why does early intervention matter so much?
Well, I think first of all, what changed the trajectory of this case is the bedside nurse trusted their gut. They had a patient, they had a bad feeling about it. They called for an assessment and they were worried that the trajectory was being missed. So they called for help. And I think fundamentally the confidence, the security to be able to make that phone call was the thing that made the difference. And that allows us to have time to get a CAT scan, to assess the patient, to identify a perforation or an aspiration, and then get your source control, start your antibiotics, and resuscitate this patient before the physiological wheels have fallen off, before rescue becomes, sometimes impossible.
Yeah, good. So we talked about the nurse-doctor interactions when there's a resuscitation. There's all hands on deck. We got to go real fast, and everyone has a job to do and a task. We have to knock these things out, or the patient's going to die. Okay, that's a very different vibe than maybe how we would collaborate in this one. So how would you so we show up together to this rapid response. How would you see this going down? How can we work together as a team for this patient?
Oh, this is a much more relaxed rapid response. This is totally different. So I think this is a case where we can gather a little bit more information, get the bedside nurse, the primary team there. We'll talk about the patient's trajectory. We'll make sure that the nurse and the primary team who've already discussed the patient today have a chance to make sure that everyone's working on the same shared mental model, has the same level of concern about this patient. And then we can start thinking about additional diagnostics. We can do a blood gas. We can send the patient for a CT scan. We can do blood cultures, make sure they're on appropriate antibiotics, and just do all of the things that we know will improve the survival of this patient.
Yeah. So it's more like a great team discussion rather than barking orders to knock out all these tasks. I much prefer this than some crazy recitation. People assume oh, you're a rapid response. You must just be an adrenaline junkie. I'm I'm actually not. I'm kind of lame. I crochet for fun, What I love about resuscitation is the opportunity to bring calm in the chaos. But here, we don't have to have chaos at all. We can just vibe on this together in a calm approach and get the patient what they need. Everyone walks away feeling what a great team I work alongside. Look at all we accomplished together. Yes, I love this.
Absolutely. And I think this is where we can really work for the culture side of things. We can make sure that the nurse feels validated in calling the rapid response, And the provider, whether that be a resident or an APP, can leave thinking, wow, I'm so glad that so many experts came to the bedside. I really learned how to do this. Maybe I got to do an ABG or do the vascular access. And we can use it to teach, to educate, and to just form that beautiful culture that we're working towards.
Yeah. Okay. So this nurse did call the doctor and let them know their concerns. And so either the nurse didn't communicate it very well over the phone, and so the doctor didn't hear those data points that would spark their ears, like, oh, I should do something about this. Or the doctor just thought that they knew better and did. I don't know. I didn't write that into the script here, but this happens a lot actually, where the nurses, I called the doctor already and they didn't know anything else. And that's why I called you guys. Okay. So as a doctor, what are some things that trigger you to say, oh man, I should go to the bedside, or I should lean in further to this, or I should not just say, oh, everything's fine? Because sometimes the nurse calls and the doctor says, what's the vital signs? And the doctor or the nurse tells the vital signs and they are stable. And the doctor's like, okay, it's fine. I think the most common one I see is, well, what's the oxygen saturation? 94%? Oh, that's fine. There's a lot more that they can maybe ask more questions to investigate, how hard are they working for that 94%? So sorry to lead you into an answer, but what triggers you to be concerned? What are some frameworks that help you get on the same page, the same shared mental model, as you said, as the nurse?
I think this is critical. And I think that I'm also a big fan of these couple frameworks that exist out in the clinical space. The first one that I really like is the SBAR. So that's situation, background, assessment, and recommendations. And that might sound like this. I'll use the example of the patient who had a saturation of 94 that you were worried about. Because we receive a lot of phone calls over the course of the day, and it can be really, really hard to triage levels of concern or what we need to listen for. So if you called me, you said, Oscar, I'm with Mr. Smith today. He's saturating 94%, but we've escalated from room air to 60% high flow, and he is working. He's using his intercostal muscles, and I can see his neck work. His work of breathing is really worrying me. I would like you to come to the bedside so that we can assess this patient together. You can then go on to the background and describe the clinical situation, but as soon as I am walking, I am moving, I am coming to wherever the patient is while you're giving me the rest of it. Contrast that to, hey, I'm just calling you about Mr. Jones. I can't remember what I called him. His SATs are 94 and he's now on 6 liters. He was on room air before. We've diagnosed him with pneumonia on a background of COPD, so we're giving him nebs and antibiotics. If you get a chance, can you stop by in the next couple of hours and just make sure we're not missing anything? That's a totally different phone call. And it's going to really, really triage how urgently I see this patient, but also the questions that I'm going to ask you over the course of the conversation, and really make sure that we leave the phone call both with an understanding of what's going to happen next. Because what I'd hate is for you to be worried about a patient, me not receive that worry, and not see the patient for an hour or so.
Can I add one more thing to your SBAR education? So situation, background, assessment, recommendation. I think what stumps a lot of nurses, they're like, I don't have a recommendation. I just know something's up. The recommendation could just be, I recommend you come look at the patient. It doesn't have to be, I recommend cephalosporins and a CAT scan. You don't have to recommend the intervention or the diagnostic. You just have to communicate your concerns. And maybe the recommendation is, would you come by and see this patient? All right. So that leads us to the next framework, how to communicate when you really are concerned for this patient.
Yeah. So there's a framework that I do really like called the CUS framework. And that stands for concerned, uncomfortable, and safety issue. And I think this can be framed in 2 different ways. So the first is when you call me and we discuss the patient and I give a recommendation, so I'm there as the rapid response team. And there's a clinical scenario that doesn't jive well. You can then say, Oscar, I'm concerned about this patient's ability to protect their airway. That's something we talk about. If you're really worried, you can say, Oscar, I'm pretty uncomfortable managing this patient on the floor. I really think they should go to the ICU. That's going to perk my ears up. Now, we will definitely discuss it. It will probably change what we're doing, but it's something I'm really, really going to listen to. And then, Oscar, you can't leave a ventilated patient on the floor. This is a safety issue. Obviously, I never do that, But, that's where we start really, really making sure that we're figuring out how to best manage this patient and make sure that safety isn't compromised. So I really like that because I'm a big fan of shared languages. And if we're all using these frameworks, we can all use the same framework to communicate how worried we are about an individual patient.
That's good. So using these particular words should perk the ears of everyone in the room when they hear someone, whether it's a doctor or a nurse or a respiratory therapist, someone says they are concerned, uncomfortable, or this is not safe. That should perk everyone's ears up to like, okay, let's reassess, let's discuss.
And I think crucially, anyone, it could be the medical student or the nursing student, like everyone should feel empowered to use these frameworks to make sure that the patient's being managed, appropriately.
Agreed. All right, let's talk a little bit about your research. From what you have researched, the delays in rapid response team activation, does this case reflect anything that you have found in your research as well?
I think it beautifully reflects some of the work that I've done. We really looked at the association of, if you look at rapid responses and then you split them into different levels of instability, how important is the delay after they meet certain criteria to the time that the rapid response is called to how the patient does? And what we found is we found an association between increasing delays and patient mortality over just the next 7 days. And we found that was really most marked when we considered patients with kind of moderate to moderately severe deterioration. So it was less impressive in patients who were not that sick, who only, maybe had a few vital sign abnormalities. And it was less marked in patients who were really, really sick, like our patient from the evening, that first patient we discussed. And what we kind of hypothesized is this association may just represent a group of patients who are sick enough that they could benefit from a timely intervention, from a timely rapid response, but not so sick that physiology has happened already and that rescue just becomes so difficult.
Okay, that's good. So I hope everyone that hears that is inspired and encouraged to speak up early and advocate for your patient, because we know it improves outcomes. That earlier is better than waiting until the last minute. Even if the ICU nurse that comes is rude and condescending, even if the doctor says, this wasn't even a number, it's better just to call than to wait until the patient declines to the point that it's hard to or impossible to resuscitate. Okay, so as we close, I want to do a couple rapid fire questions with you.
Okay.
If you were talking to maybe a new resident, maybe a new nurse, what would you say are like the top 3 or 4 early signs that you should not ignore? Ones that wouldn't maybe flag the chart to turn red, but something you should kind of hone into.
Excellent question. I think that there are a few. I think the ones that are kind of best supported by the literature are going to be new tachypnea, particularly if there's respiratory distress associated with that. Mental status changes, however subtle. The thing that I think gets really missed is that patient where you ask them their orientation questions and they just kind of take a little bit of time and then get it right. That's still dysfunction. I still struggle to write down what that is in my note, but that's real. And then I think new hypoglycemia, particularly on a patient who's not on insulin, or unexplained hypoglycemia, I should say. And then when you're looking through your labs, if you see a new anion gap that just cropped up out of nowhere or a very low serum bicarb, something's going on. That's a patient who needs a blood gas because I've often found kind of unexpected elevated lactic acid, which isn't always septic, but it does always require that you do a little bit more investigation.
I just want to echo that and say I am the chair of our Code Blue review committee. So we review every Code Blue that happens in the hospital, not just how the Code Blue went, but leading up to it, something that we could have maybe caught earlier. And those are the indicators we often see where the lab values from the morning, the bicarb was 11. And no one really thought anything of it. And the patient coded later that day. There's so many little things that maybe don't seem a big deal until you look, hindsight 2020 shows you, oh yeah, this patient was telling us something was a brewing before they ever coded. So yes, these are the ones: tachypnea, mental status change, hypoglycemia, and then what's happening with their metabolic system. Are there some changes there? Thank you. Okay, final question. What would you say to a nurse who's worried about overreacting? What advice would you give them as the person who would be responding to their reaction?
I would, and I hope my colleagues across the country, across the world would give the same advice, which is we would much rather be called early. If you're calling early, you're going to call on a few patients who didn't need to be called, but you're also going to call on some people who are going to get saved. So don't worry about overreacting. Worry about underreacting. And anyone who overreacts to you overreacting, that's their problem. Keep the patient in the center. We're all doing this to save patients, to keep them safe. And I would say there's no such thing in overcalling a rapid response or overreacting to your own gut feeling or your concerns.
Amen. I agree 100%. Oscar, thank you so much for talking through this case with me. This has been such a valuable discussion. The ability to reflect what could have happened if we had caught early and what does happen when we wait too late. Before we close, though, I did want people to know about the Revive conference that's coming up in March. Can you just take a moment to tell my listeners about it? Because they're probably going to want to come.
Well, thank you so much. As you may have picked up, I am really, really passionate about resuscitation, and I'm equally passionate about cardiac arrest and education around cardiac arrest. So Revive is a conference that we're hosting in Philadelphia on March the 14th. So coming up, it is dedicated to everything cardiac arrest. So all of the new guidelines, airway management, post-arrest care, mechanical CPR, you name it, we're covering it. It's going to be a one-day educational CME event, unbelievably immersive. We've invited the best educators from across the country, and it's going to have both remote options and in-person hands-on options for this incredibly enjoyable, hands-on, resuscitative bonanza. And I'm so excited to share the learning and the experiences with you and with the attendees from hopefully across the world.
Well, I share your excitement. I am so excited about your speaker lineup. When I went to the website, I was like, oh my gosh, this is going to be a high yield. One day, we're going to fit all this into one day. This is going to be awesome. I will be there. So I'm super excited for this conference. I cannot wait. If you would like to attend with me, Oscar and his team actually have given me a coupon for all the Rapid Response RN podcast listeners. So if you can use the word RAPID50 to get $50 off the cost of the conference, I will put a link in the show notes for you if you want to learn more. I hope to see you there. Oscar, thank you again for your time today. I look forward to seeing you in person at the Revive conference in just a few months. To everyone listening, I hope this episode inspires you to trust what you see, trust what you feel, speak up early, and that phone call might be the difference between two very different endings. All right, Oscar, thanks again. Have a great day.
Thank you so much for having me, and Happy New Year.
Yep, see you in a few months.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as The Rapid Response RN.